Welcome to the ACHD Congenital Heart Disease Basic Course. My name is Helmut Baumgartner from Münster, Germany, and it is my pleasure to address the patent ductus arteriosus in the adult. As a brief background, PDA may occur either isolated or in association with other defects. In this talk, I am exclusively addressing the isolated PDA. As a connection between the aorta and pulmonary artery, it primarily causes a left to right shunt, and if this is significant enough, this will cause left ventricular volume overload. In the presence of a moderate to large duct, there will also be pressure overload to the pulmonary circulation and an elevated pulmonary artery pressure, and eventually pulmonary vascular disease will occur. This is not solely determined by the shunt volume. Probably there are some genetic reasons and genetic predisposition that determines the development of this complication. If the duct is really large, Eisenmenger syndrome will develop. There are very rare complications encountered, such as endarteritis or duct aneurysm. Patients with a PDA during adult life may either present as patients who had already closure during childhood. Most of these patients will present with unremarkable findings. There will be no residual shunt, normal left ventricle, normal pulmonary artery pressure. Now, these patients do not need regular follow-up visits during adulthood. There may be, however, the rare patients with more or less residual shunt, the rare patient who has pulmonary arterial hypertension despite closure, mostly patients after delayed closure, and the rare patient with LV dysfunction. In the group with unrepaired PDA, we have to distinguish the ones with small PDA. They have a normal left ventricle because the PDA is too small to cause volume overload. There will also be normal pulmonary artery pressure and no symptoms. In the group of patients with a moderate PDA, we have to distinguish between those with still predominance of LV volume overload. They will present with an enlarged left ventricle with normal or already reduced left ventricular function, and clinically they may present with left heart failure. The other group of patients with moderate PDA will present with the predominance of pulmonary arterial hypertension and therefore signs of pressure overload of the right ventricle and clinically right heart failure. At the end of the spectrum, we may see the patient with PDA Eisenmenger, and they will present with differential cyanosis. I will come back to that later. Some typical examples. This is echocardiography of a patient with small PDA. We see in the color Doppler image the jet from the aorta into the pulmonary artery. By continuous wave Doppler, we see the high velocities throughout systole and diastole, indicating that there's normal pulmonary artery pressure. And the short axis view of the right ventricle and the four-chamber view show normal ventricular sizes, normal ventricular function, normal atria, so apparently this is a small PDA without hemodynamic significance. This is an example of a patient with moderate PDA. Nicely seen in the color image that this is now a larger duct by continuous wave Doppler, a dense spectrum, still high velocity, but already some elevation of the pulmonary artery pressure. The short axis view of the left ventricle and the four-chamber view clearly showed that there is severe left ventricular volume overload. The right ventricle looks rather small. There is no overload to this ventricle. This is another patient with moderate PDA, and from the color Doppler image you would even estimate that this duct is smaller than in the previous patient. Nevertheless, continuous wave Doppler shows, although still continuous left to right shunt, low velocities indicating pulmonary arterial hypertension, and the short axis view of the left ventricle and the four-chamber view again demonstrate that there is severe pressure overload to the right ventricle. We see the flattened interventricular septum, the enlarged right ventricle, still maintained right ventricular function. As an additional finding, we see this markedly dilated pulmonary artery. Finally, this patient actually was referred to our pulmonary hypertension unit. The patient obviously has severe right ventricular pressure overload. There's a markedly enlarged right ventricle with severe hypertrophy, a flattened interventricular septum. There's only mild tricuspid regurgitation, but it can be appreciated that this is with very high velocity, indicating severe increase of right ventricular pressure, and the lack of any obstruction as seen in the short axis views in the right ventricular outflow tract actually confirms that there is pulmonary hypertension. There's no indication for a PDA. However, when examining this patient carefully, we see that he has normal hands and normal fingers, but his feet are cyanotic, the toes show clubbing, and by pulse oximetry, we can confirm that in the fingers there's normal oxygen saturation with 95%, whereas on the toes there's desaturation with 86%. So apparently this patient has differential cyanosis and therefore he must have a PDA. This is nicely confirmed in this patient with CT scanning. You see this large duct connecting the aorta and pulmonary artery. Even nicer seen here in this 3D reconstruction. The large duct with Eisenmenger syndrome. So I would summarize for diagnosis. Physical examination with auscultation is essential as long as we have still a continuous left to right shunt. We will hear a continuous systolic diastolic murmur. Differential diagnoses are aortopulmonary window, ruptured sinus valsalva aneurysm, aortopulmonary collaterals, coronary fistula. In patients with severe pulmonary hypertension, we may be faced with only a systolic murmur. And in those with Eisenmenger syndrome, and on the other end of the spectrum, the ones with the very small duct, the so-called silent duct, we may have no murmur. Depending on the situation and the severity of the disease, clinically we may have signs of congestive heart failure, either left or right or both, and in the Eisenmenger patient, differential cyanosis. The ECG again depends on the severity of disease. In mild duct it may be normal, and depending on the severity there may be either signs of LV left atrial overload or right ventricular overload. Echocardiography obviously is the key diagnostic tool. In some patients MRI and CT may be required, and the patients with elevated pulmonary arterial pressure require careful further hemodynamic elevation with catheterization. This brings me back to the patient I have demonstrated with moderate duct and severe pulmonary hypertension, this 38-year-old. Echocardiography findings are summarized here. She has PDA with severe pulmonary arterial hypertension. LV size and function are normal. There's markedly enlargement of the right ventricle with preserved right ventricular function, mild to moderate TR, massive pulmonary artery dilatation, and pulmonary artery pressure is only slightly lower than systolic pressure in the systemic circulation with a PDA gradient of only 25 millimeters mercury, but there's still continuous left to right shunt. Heart catheterization confirms severe pulmonary hypertension, still slightly lower pressures than in the systemic circulation. There's still significant left to right shunt with a QP-QS of 1.8, transpulmonary gradient 54 millimeters mercury, PVR 8 Wood units, no significant changes with nitric oxide testing. Because of the still significant left to right shunt, we went ahead, did in the cath lab balloon testing, and although there was only slight decrease in pressure because there was no worsening of hemodynamics, we went ahead and prepared for closure. We used an ambulatory device coming from the pulmonary artery. This was implanted into the duct, as you can see it here. Immediate angiography still shows some residual shunt, but this will resolve after a few days. A PDA closure percutaneously is a very safe procedure. In the adult patient, it's preferably done with occluders, such as the ambulatory duct occluder, better than with coils. This is just one example of the publications, more than 200 patients in this series, pediatric as well as adult patients. Success rate very high, 205 patients successfully closed, complete closure during follow-up in 204. Only in the early phase, during the learning phase, a few embolizations, so this is a very effective and very safe procedure. In our patient, already on the next day, there was a significant drop in pulmonary artery pressure to 60 millimeters mercury systolic pressure, and already some remodeling, as you can see from the four-chamber view. During follow-up, there was a further decrease, almost normalization of pulmonary artery pressure over 1 year, and significant improvement of the patient's symptoms. This is the other patient I have shown before with the moderate PDA and predominant LV volume overload. Now, these are, of course, the patients who are ideally treated during adulthood. There's no significant pulmonary vascular disease in this patient. After closure, as you can see here in these images, there is very rapid remodeling, normalization of left ventricular size, still normal function of the left ventricle, normal pulmonary artery pressure, and the patients got rid of any symptoms, was asymptomatic after this procedure. This table summarizes the indications for PDA closure. This is taken from the European recommendations, but the Americans are very similar. PDA closure is indicated in all patients with signs of LV volume overload, in all patients with elevated pulmonary artery pressure, but still pressures less than 2/3 of systemic, and pulmonary vascular assistant less than 2/3 of systemic, and device closure is the method of choice. All these are class 1 indications. The patient with even more severe pulmonary arterial hypertension with pressures greater than 2/3 of systemic or pulmonary vascular assistant greater than 2/3 of systemic should be considered for closure as long as they have still significant net left to right shunt with a QP/QS greater than 1.5, or when testing, preferably with nitric oxide, or treatment for pulmonary arterial hypertension demonstrates pulmonary vascular reactivity. Device closure should also be considered in patients with small PDAs as long as there is a continuous murmur, because the risk of intervention is so low. PDA closure should be avoided in patients with silent duct, and it definitely must be avoided in the patients with Eisenmenger. How should we follow these patients after intervention? Echocardiography is essential and provides LV size and function, pulmonary artery pressure, eventual residual shunt, and associated pathologies. Patients without residual shunt with normal LV and normal pulmonary artery pressure don't require regular follow-up after 6 months post-intervention. However, patients with LV dysfunction and patients with elevated pulmonary artery pressure should be followed in 1 to 3 year intervals, depending on the individual findings. Finally, exercise and sports. There are no limitations in patients without pulmonary arterial hypertension. For pregnancy, again, only the patients with pulmonary arterial hypertension are at increased risk. Endocarditis prophylaxis is only indicated in patients with implants with residual shunt and during the first 6 months after intervention. With that, I thank you for your attention.